I think at the meeting there were several other key data sets that were presented, especially at the plenary session by Dr. Drayling with regards to a randomized phase 3 study which is the Triangle study in patients with frontline transplant eligible mantle cell lymphoma. The standard of care so far has been for patients with mantle cell lymphoma, we typically treat them with upfront intensive chemotherapy followed by an auto-transplant in response, followed by rituximab maintenance. Clearly, autotransplant has toxicities, and this clinical trial really was trying to figure out if adding BTK inhibition with or without an autotransplant in the upfront setting could yield better or similar benefits. The net is that this clinical study showed that with regards to its primary endpoint, which was failure-free survival, the arms that contained ibrutinib with or without an autotransplant did better as compared to autotransplant alone. So that kind of begs us a question now, do we even perform autotransplants in the frontline setting if we were to treat our patients with ibrutinib plus chemotherapy? I think a little bit more follow-up would be good, but all in all, the FFS, or the failure-free survival endpoint, has been met. So I actually would be super excited to see what our practice patterns look like over the next few months. Maybe some of us would start incorporating BTK inhibitors without an autotransplant in the upfront setting.